Good morning, good afternoon, and good evening, everybody. My name is Saleh. I'm the CEO of CeramTec.
My pleasure to host the third edition of Orthopedics Meets Dentistry. When I started med school, the future dentists and physicians had a common track, but then after 2 years, we lost sight of each other. Now we deal with the same problems, finding the best solution for treating patients, finding the best material to treat our patients. So this is the theme of the third edition. And without further ado, I'll hand it over to our host for tonight, Mr. Niklas Keller. Thank you.
Thank you very much. It's a pleasure to be here, also from my end. Welcome to the third CeramTec virtual roundtable on Orthopedics Meets Dentistry. My name is, as already mentioned, Dr. Niklas Keller. I will be your host this evening. I'm a psychologist by training, specializing in risk perception and medical decision making, which is part of the reason why I've been asked to host this event. I will just let you know a little bit about the structure of today's virtual roundtable. We will first have 3 very esteemed guests that we will question. There will be a series of questions for each of these guests. After each question session with each guest, there will be an interactive live voting session where we would like to get your input on particular issues that are facing those disciplines today. After those 3 interviews and live voting sessions, we will also then have a panel discussion. And with a little bit of luck, if I can keep the time properly, then I hope we can also get to a Q&A. You are very welcome to submit your questions that you might have to myself or, of course, to our esteemed experts in the panel throughout the entirety of this virtual roundtable. And then we will try to select the most poignant questions at the end, as much time as we have. This time is the third roundtable, and we will actually look at a particular topic and theme. We will see what drives medical decision-making. Is it evidence or is it clinical intuition? So this is going to be the guiding question that we will have today. But before we get into this topic, I would like to first introduce the guests. And as I already mentioned, there are 3 guests that we are hosting here today. First off, I would like to introduce Professor Dr. Rihard Trebše. Professor Trebše is an absolute top-level orthopedic surgeon. He works as the head of service for bone infections at the Valdoltra Orthopedic Hospital in Slovenia, where he is also the deputy director. And he is also a highly accomplished researcher with many publications, and he has published numerous landmark studies, particularly on the treatment of prosthetic joint infections. Very welcome, Rihard Trebše. Thank you.
Thank you.
Secondly, there is Dr. Miguel Stanley. Dr. Stanley is one of the rising stars in the field of dentistry, having been recently voted as one of the 100 most important dentists in the world today. Congratulations for that, by his peers nonetheless. He is the founder and director of the White Clinic, that's a dental care center, as well as the Slow Dentistry Global Network, which is which focuses on patient safety and patient experience, and is operating in 60 countries across the globe at this point in time. And Dr. Stanley believes that the golden age of dentistry is yet to come. So we would like to hear more about that when we ask Dr. Stanley. Welcome, Dr. Stanley. And last but not least, we have Professor Dr. Dirk Stengel, esteemed colleague of mine. I've worked together with him. Very nice to see you here. Professor Stengel has the very rare, and you might perhaps call it a somewhat schizophrenic property of being both an accomplished and highly published epidemiologist, holding an MSc degree in epidemiology and a PhD in biostatistics, as well as being a board-approved trauma surgeon. So this is certainly a combination that you see very rarely. And he's a member of the Cochrane Injuries Group and a Cochrane Reviewer. And he also advises the government, the German government, on issues of methodology in medical science and medical studies. And of course, he's also a full professor at the Charité University Hospital, Berlin. Hello, Professor Dr. Stengel. Nice to meet you. Nice to see you. So let's get started right with the questions for our panelists. And first, I would like to start with Professor Dr. Richard Trebše. The first question we have to you, Professor Trebše. You are a revision surgeon with extensive experience in very complex surgeries. What would you consider to be the worst revision that you have worked on so far, that you have experienced in your time?
Thank you. Well, I performed more than 1,000 revisions, actually, and it is very difficult to say which is the most difficult, the most complex. But what I fear the most is when this old lady is coming in saying, okay, this hip, it's after 30 years, it's becoming to start being painful, we need to do something. And then we do the x-rays and you have this catastrophic bone status, but in a lady with a weak general condition, but she's still doing quite well. So if you wait, it can result in a big catastrophe, but doing something, it's very difficult to achieve a better functional result with these catastrophic conditions. And of course, she needs to survive this very difficult surgery. So good patients with catastrophic x-rays are the worst nightmare for me.
Okay, thank you very much, Professor Trebše. Is there kind of like a top ranking of headache revisions, say your top 3 of all time headache revisions that you have? What would they be?
Well, again, it is difficult to name just the top 3, but one is for sure the most important is the general patient status. It is very difficult to do a complex issue in a very weak patient. The other important issue is soft tissue conditions, because at the end, patients judge the quality of the surgery and the outcome not on the longevity of the implant, particularly not with revision, but on the functional status that you can achieve afterwards, and that relies on soft tissue conditions that you encounter in the joint and the soft tissue conditions that you can improve or do the surgery on those. So next, it is implant status. So if you have an infected patient and very long and integrated implants, it is a very big nightmare. I don't fear infections very much. I have quite a good relationship with infections, and I fear the least the difficult bone status. Because with fancy implants that we have, it is nearly not possible to have a condition that is not treatable with those. But of course, the most problematic are when there are complex issues related to all 4 previous types of conditions.
Thank you very much, Professor Trebše. Now, you said that you have a good relationship with infections. I've never heard it quite put that way, but of course you are also known for being one of the first, if not the first person to hypothesize an association between the bearing materials used and the preponderance of infections. What was it that initially drew you in that direction, and what is that? How do you explain this phenomenon?
Yes, well, in the hospital we have a registry. Since local, it was first local. Now it's the country registry, and my colleague actually, Dr. Simon Kovac, he noticed that we, in our large series of metal implants, we have 4 times higher infection rate than in ceramic on ceramic patients, where the same surgeons were there and the same patients, actually both with metal and ceramic were both young patients that were treated with total hip arthroplasty. And the polyethylene patients were somewhere in between. And then we know that about the 30% of the patient of the explants are colonized. So I hypothesized that maybe the local tissue status keeps this 29% of colonized patients in check, so they do not become a manifest infection, and only about 1% gets into an actual infection. And actually, we noticed that in some, when the biologic drugs for reuma patients were being introduced, some patients just after introducing these biologic drugs just started to leaking. So they obviously had a low-grade infection in there, causing no problems, but then with the reduced immune status, they started to leak and to develop a fistula. So I think that adverse tissue reaction does compromise local immune status around the implant, and those infections or colonization that are clinically completely silent then become symptomatic. And this is particularly true with metal on metal, maybe less so with metal on poly, and the least important ceramic on ceramic, where local tissues are nearly intact.
Thank you very much. Yeah. So, of course, infection is one of the risks of THA or THR, but there are many others. Just very generally, since we are talking about also risks and risk perception in general today during this roundtable discussion, what are your strategies in THR to assess and mitigate risks generally in your own clinical practice? And do you have maybe a hierarchy as well or certain prioritizations how you want to mitigate risks?
Yes, I think this is a very important question. And based on my experience, I think it is the most important to get all the thinking out of the surgery. So the thinking needs to be performed before surgery. So all the planning, the setting, the team, the OR, the equipment, the tools, the implants, so everything needs to be discussed and arranged in advance, and having plan A, plan B, plan C, and of course, in the beginning, discuss the patient about everything that can happen, and then it's just a matter of execution. And surgery is an execution of a previously well-prepared plan. Because when you start thinking under stress during surgery, that thinking does not go well. Usually you just think how to get out of the problem and not how to solve it in the best way. So you need to have plans, a hierarchy of plans, and you need to do everything in advance.
So you would not say that you are somebody that that says, okay, intraoperative decision making is an important skill in THR. So you would try to actually outsource all of that intraoperative decision making to before when you're planning the surgery. Okay, so you're an ardent supporter for checklists, I'm assuming as well, and maybe you have read the checklist manifesto as well, probably. Yes.
I did.
Yeah, very good. All right, thank you. So how are the strategies that you use in practice are supported? Are they usually the strategies that you use to, for example, mitigate risks, or when you do prepare the steps or contingencies that might arise during a surgery, are these based on evidence, or does intuition also play a part? Do you have, say, a hunch that for a particular patient it might be more important to prepare alternative plan D instead of alternative plan C, perhaps?
Well, I'm a kind of the person that does not understand very well what intuition is. I usually rely on evidence. The best evidence, I think, is the one that you produced by your own studies, because you know what's the quality behind. Then the second best is those when you know the person that performed the studies, and then you use the evidence for that. And if you don't have the evidence for everything, which is very frequently encountered in orthopedics, then I think logic is above all. So if you have a correct predispositions and correct base points, then you make just the logic assumption. And then I usually try, when I don't have the evidence, then I try to treat or to act based on logic on the most strong basements that are available.
Thank you very much. So you just set up a little bit of a different. There used to be this this concept going around of a hierarchy of evidence, with randomized control trials being the pinnacle of the evidence pyramid, so to speak, and going downwards from there. Your pyramid seems to have somewhat different setting, being own evidence is the best evidence, and then people you know and trust. So that's a good take. Thank you very much. We now have, thank you very much, Professor Trebše. We are now going into our first live interactive voting session, where we would like to ask you, everybody that is currently watching in the stream, in the live stream, where do you see an association between implant material and infection? And you have 3 answer options: yes, no, or I don't know. And we would very much like to hear your opinion and your views on whether you see an association between implant material and infection. And I will get from the editorial team a little signal when we're done with the live voting, and then I shall continue with Dr. Stanley.
Hello. How was everything?
Very good, very good. Dr. Miguel Stanley, it's very nice to have you here. Very pleased to see you. So I'm going to dive straight into it. Dr. Stanley, you have stopped using metal implants on your patients. Was there one particular trigger or one particular event or one particular experience that made you say no more metal for us?
Well, I wouldn't say I've stopped completely. I would say that I have started a conversion to majorly ceramics. And again, it depends on the patient. So there are colleagues of mine, there is a growing trend of clinicians around the world that are switching to a complete ceramic. I'm still in the process of that transition, but I'm trying to use data and science to understand that transition. So dental implants go back to almost 5 decades. They were first introduced by a gentleman called Brannemark in Sweden, and there's a lot of 50 years of evidence about titanium dental implants in dentistry. And over the last decades, designs have changed, surface has changed. We've got grade 4 titanium, grade 5 titanium, and which are alloy enriched. And it is my belief that there's a huge part, my belief and a bunch of science and colleagues that back this up, that some patients are intolerant to the metal, and they're having poor reactions to this. And if we go to what my colleague said previously, it doesn't seem to affect everybody. I don't think we have all of the information yet, but clearly there's a growing trend amongst my patients asking immediately to have a metal-free solution in their mouths. We saw this transition happen in the teeth, the actual prosthetics that for decades were metal, so ceramic fused to metal. And in the last 15, 20 years, people want full ceramic restorations done. And that trend is now going past the gum into the bone. And patients themselves are asking for metal-free solutions. And what we're seeing is very, very exciting. And I would agree with my colleague that we're looking at a lot more integration of soft tissue and bone tissue. It appears that it much prefers the ceramic fixture. So it's an exciting time for dentists. There's a lot to learn. There's a huge learning curve associated to this, and we have to follow the science and we have to follow the data. But it's a very, very interesting transition that I predict for the future of dentistry.
Thank you very much, Dr. Stanley. That's certainly a fascinating development. Now, you have just said that there is a big switch coming. Basically, that a lot of your colleagues are switching to full ceramic. However, there are still probably also many of your colleagues that are still distrustful of using ceramics and prefer, using the basically still somewhat of the gold standard of titanium, right? So how would you say, where did your trust for ceramics came from, and how could you generate trust for ceramics? What was the?
It's a really big question. First and foremost, I don't think that we should create any fear around titanium. We have to be very cautious about that. There's hundreds of millions of people around the world with titanium, and that won't have any health issues with that. What I'm talking about is that there might be a percentage of the population that could have an effect with that. And much like gas cars transiting into electric vehicles, we're seeing that happening on the streets today. I'm thinking that the future of our profession in medicine we'll start seeing, much like we saw in hip surgery, a transition to fully ceramic. We are in the beginning. I would say that ceramic implants represent not even 2% of the global market. It's going to be a growing trend. We have to be realistic. Ceramic implants cost a lot more money than titanium implants, and there's way more data proving that titanium implants work. So I'm not somebody here to cause panic or fear or anything like that. And I don't think anybody should be made to feel bad for driving a gas car or driving an EV car. It's a personal decision based on your personal congruence. Mm-hmm. Me personally, I'm seeing a lot of interesting reaction on my patients and in the biology around ceramic implants. So we're just seeing a very interesting integration of the gum, not just the bone, but of the gum around these ceramic fixtures that we don't really see around titanium. So I think the future is very, very interesting with this material.
Great. Thank you very much. We have now also got the results from our first live voting. I'm just very quickly going to interject those results here. So we asked you, do you see an association between implant material and infection? And out of all of those that have voted, 77% said yes, they do see such a connection, such an association. 5% said they don't see such an association in their clinical practice. And 18% were not sure, did not know whether such a connection exists, such an association exists. All right. So also the question to you, Dr. Stanley, what would you say, what are the key risks in dental implantology, and how would you rate them, and how would you manage them?
That's a huge question. So I'm just going to put a few ideas out there. Yeah. So obviously a titanium implant where we have a lot more data, they're very resistant, they're very strong, and the new grade 5 titanium implant, well, the other versions are a lot more resistant to fracture. And there's this belief that ceramic or zirconia implants have a higher capacity for fracture. That is not my experience. These new designs, the new manufacturing processes, even some of the products you guys are making, these are very, very resistant mechanically, and once in the bone offer identical mechanical properties to their titanium counterparts. That's the first thing. Also, we have a lot of data showing that coming from prosthodontics, that the gum absolutely loves zirconia. We all know that we should polish zirconia crowns because the actual soft tissue really interacts directly with the ceramics. So bringing this into an implant is just very, very clever. And also, we believe, much like my previous colleague said, that this is less prone to infection and the colonization of the oral pathogens. And unlike the orthopedic surgery in the mouth, we've got over 400 pathogens that have to coexist with the work that we're working on. And one last very important thing is the importance of vitamin D in integration with any type of implant for that matter, because we've also studied, and we wrote an article on this, if patients' vitamin D is low, that the acceptance rate of these implants is also exponentially lower. So we also have to look at systemically our patients' overall health before placing any type of implant, but specifically with ceramics. But again, it's an amazing, new, exciting field, and we're really looking forward to the future.
Excellent. And you've already also started moving into the next question that I was going to pose to you. So we've talked about using ceramics, but we've also talked about using vitamin D as a very important aspect to mitigate or manage risks. What are other strategies that you use to manage risks for your patients?
It's a great question. I think, like any doctor, I mean, most dentists operate in a private sector, so it's elective surgery, and there has to be congruence between the science and the doctor and the patient, and so case acceptance is critical. I would say the foundational is bone volume, so the phenotype. A patient that has a good amount of bone, a good amount of soft tissue, we all know from the data that will have a higher degree of success on any implant. So, even a bad implant placed by an inexperienced surgeon, if you've got a lot of bone, it's going to integrate. We also know that bone compression, so you don't want to over-compress your implant into or over-torque it into the bone because compression can cause ischemia. So bone site preparation is of paramount importance. And again, simple things like I don't operate smokers. That's a personal decision of mine. But in the oral cavity, we know that smoking is very, very bad for the blood vessels, and we've known that the data is relevant. So when I want to have success with my patients that are looking for optimal health, I think that not operating smokers is very important. Patients have to also contribute to the overall outcome. And this comes to a shock to many doctors. But again, if my job is to have success, I think my patient also has to work to contribute to that overall success. And yes, vitamin D supplementation, good oral health. There's a lot of factors that can contribute to success. And the quality of the implant is one of them.
And which also brings us to the factor which we're not directly talking about today, but shared decision making, bringing the patient into the process of healing. So you mentioned data a lot of times. You said, for example, that there is much more data on the titanium than there is on the ceramics, but yet you do use ceramics. So how important in your medical practice is the scientific evidence, and how much do you rely on science and data, but how much do you also rely on your experience and your clinical intuition when you perform surgery, and also when you beyond surgery are involved in patient care?
It's the question that is the important one of the day. I mean, my mother had a hip surgery earlier this year. I demanded that she had a ceramic hip done because I was seeing what was happening with a lot of patients with failed and outdated implants, let's put it that way. I think we are facing an entire new wave of patients that are going to be seeking a new way to treat their oral problems. So patients that placed implants 15, 20, 30 years ago are going to want and need to upgrade that. And I think it was Einstein that said, only a fool does the same thing twice expecting a different outcome. So I think that now with these new materials like ceramics, patients that are now going for their second or third time are going to be demanding ceramic fixtures. And my feeling and my intuition and my experience is that this is a better biomaterial. It's more organic. And some studies that we're investigating in is that there's a large portion of the population that are intolerant. They have hypersensitivity to titanium. It's not everybody, but we have to look into the future, our genetic code. Not everybody reacts the same to this metal. And we know dentistry is moving into metal-free, healthcare is moving into metal-free. Let's just look at our supermarkets. Supermarkets have gone biological, organic, GMO-free, pesticide-free. The consumers are getting smarter. They want smarter things in their bodies. And I think that this is going to be a consumer-driven revolution. And I think ceramics have a huge role to play. And our intuition is that, look, we're private practitioners. We have to be ready for this revolution, which is the conversion from metal to ceramics. And it's inevitable. It's coming. So let's best get prepared for that.
Great. Thank you very much. for answering our questions. Thank you very much, Dr. Stanley. We are now at our second interactive voting session. There's a second question that we would like to pose the audience. So do you believe that oral health has an impact on the outcome of joint replacement surgery? Do you believe that oral health has an impact on the outcome of joint replacement surgery? One yes, no, or I don't know. And we will continue with our last third panelist, Professor Stengel, while we gather your votes. And then in between, I will also let you know of the voting results again. Professor Stengel, good to see you.
Hi, Niklas. Hi. Thanks for moderating the session. So I'm really privileged
very happy to do so.
Be on the panel.
Professor Trebše and Dr. Stanley just mentioned that they rely on a lot of evidence and data. So, I mean, you being an epidemiologist, when you're wearing an epidemiology hat, must be very happy about that, right? So,
yeah, what do you think? I mean, there are two hearts beating in my chest, So, I really love Dr. Stanley's holistic approach on biological and functional full mouth rehabilitation, which really differs to my experience as a patient. I should probably make an appointment at your clinic. So I'm non-smoker, I promise. So of course, it really comforts me to hear that these fine guys here use scientific information managing their patients, but they probably are rather the exception than the rule. So there's still much arbitrariness out there, especially as Dr. Stanley mentioned in private practice, of course. And there's also a huge difference between relying on any data and the best available evidence on a certain clinical topic, and also from research appraised in a systematic and critical manner. So I cannot stress this enough. Of course, I mean, if you're trying to play hide and seek, it is impossible to hide yourself from evidence. I mean, there's always evidence contamination. For example, I mean, during the COVID pandemic, we suddenly had about 84 million experts in Germany on COVID. So just because of the media coverage, and so in fact, it's really nonsense to think of any science-free clinical surrounding or scenario today, but it matters how information is sought, evaluated, and also implemented in practice. I mean, we all are aware that time is precious. It's a precious resource, not only in a clinical practice, but in everyday life. And it's a currency by itself, which affects all healthcare providers, not only doctors, but foremost nurses, especially in the hospital, of course. On the other hand, I mean, there are more than 3 million biomedical papers published a year, and it can be really frustrating trying to keep up to date. So healthcare professionals must learn to separate the wheat from the chaff, and also to formulate an answerable question that can be solved by the data that you retrieved during your literature search.
Very critical skill, especially trying to formulate, there's the PICO scheme, for example, which helps you to formulate questions.
I mean, researchers and scientists, they are also responsible to collect and to report data that are interpretable.
Yeah, very much so. And you very rightly say that, we're certainly not living in an age of information scarcity, so there always seems to be more than superfluous information about everything. At the same time also, we are continuously confronted with situations for which there is, for example, for that one individual patient or for a new technology, as we've also heard our previous panelists say, that there is just not as much evidence as there is, for example, for old technologies or for larger cohorts, but not the individual patient in front of you. So how do you then best combine, in your opinion, on the one hand, the evidence that is available, but also in order to be able to act as a medical professional, you will have to at some point integrate also your experience, and perhaps you might also go to so far as to say your clinical intuition for being able to practice.
I mean,
medicine.
Professor
So
Trebše said that he probably is a little bit uncomfortable with the term intuition or gut feeling or so. But I mean, Niklas, you're as a psychologist working together with Gigi Renzer, of course. I mean, you have the other side of the medal, and I guess heuristics or the gut feeling can be quite important, and sometimes it's you make better decisions with less information, especially if you're an experienced doctor, especially a surgeon.
Yeah. So you know, a lot of information can actually lead you astray, right? And I think this is also what you mean by being able to critically evaluate and separating the wheat from the chaff.
And I also must really stress that the current evidence pyramid, or whatever how you call it, is absolutely outdated.
Yeah.
And there is a very good paper where it says a hierarchy of evidence is amazing nonsense. So, and also, I mean, Dr. Stanley mentioned it. We are more and more aware of molecular data, so big data and so on, and this will also influence our clinical practice and science, of course.
Yeah. We do, I believe, have the answers of our interactive voting poll. So I'm just very quickly going to switch to that. I'll be with you very, very briefly again, Dirk. So we've got our answer. Do you believe that oral health has an impact on the outcome of joint replacement surgery? 87% of you said yes, 7% said no, and 7% said I don't know. So that's 101% that answered this question. Well, I'm rounding error, I'm assuming, but since I'm talking to the epidemiologist, I thought I'd just throw that in there. Now, you say a scientific methodology, of course, is a research field of great interest to you. You know, you can't use just scientific methodology to answer a research question. You can research scientific methodology itself. So could you maybe please explain to the audience what this is about and how do you conceive of this, and what's a layperson's, so to speak, or layperson digestible way of explaining this to us?
Yeah, of course. I mean, the first ever conducted controlled trial, can you imagine when it was? It was in the year 1747.
Was it?
And it was conducted by James
scurvy?
Yes, it was by James Lind on the HMS Salisbury, and so it was a controlled trial, or let's say a controlled experiment, whether lemon juice would prevent scurvy. And of course, in 1948, we had that iconic first randomized controlled trial on streptomycin for pulmonary tuberculosis conducted by Sir Austin Bradford Hill. But we came a long way since these first controlled trials, and but we still have to adhere to the so-called scientific method, which means it is a process of thought based on integrating previous knowledge, observing, measuring, and logical reasoning, as my colleagues already said. So, and the legendary physicist Richard Feynman, who was a Nobel laureate in 1965, made quite clear. So if your theory disagrees with experiment, it's wrong. And in that simple statement is the key of science. So in clinical research, especially in clinical epidemiology, we always claim for a causal relationship between A and B, a certain exposure, intervention, or whatever, and patient outcomes. This means, for example, there's no alternative explanation for benefit in patient-centered outcomes rather than the treatment. So this proves that the treatment really works. So patient characteristics between the treatment and the selected placebo or control treatment and so whatever must be controlled. They must be very similar to say, okay, there is a high chance that this treatment really, really works. But imagine that with the deciphering of the human genome in the early 2000s, for example, there's no progress which is really fueled in the area of personalized, individualized, stratified medicine and so on. For example, in oncology, we now have targeted therapies that are individually designed for not a distinct tumor, but for a distinct heterogeneity in the human genome, which is a fascinating approach. I mean, in orthopedic and trauma surgery, we must adopt methodological peculiarities and achievements and gauge them just to the to the differences in the field. So surgery is quite different to internal medicine, for example. So there may be also a difference between evidence-based surgery and evidence-based medicine in surgery. So one of my drivers in my daily work is to find the best trial design to answer a clinical question. But the clinical question is key. So we cannot work with our clinical colleagues, you know.
And when you pursue these answers, do you think that you sometimes rely too heavily on the numbers, or
No,
definitely
not. We sometimes rely too less on numbers, but we interpret them in a wrong manner. That's the problem. So. I'm completely with you. We are tempted to overinterpret sometimes the clinical relevance of marginal results and ignore providers' and patients' preferences. And but there's no magic behind methodology. We just have to explain it. And of course, our clinical colleagues need a practical toolbox for their daily practice. Simply just to cope with information overload.
Thank you. So the very last question, very briefly, because we're a little bit over time.
Okay.
You recently performed a best evidence synthesis regarding bearing materials in THA. So what is your general impression of the quality of the published evidence in the field and being able to integrate that evidence to actually make concrete statements?
Well, again, so the data published absolutely do not adhere to that evidence pyramid. And especially with regard to hip replacements, we really have to cope and to adhere to the results from international registries, because the results from RCTs are, let's say, they are moderate to poor. So I won't rely on most of these data, but probably on the larger scale registries established in Scandinavia, in the UK, and other countries.
Okay, great. Well, that's a good guiding light, I guess, for many a practitioner out there. Thank you very much, Professor Stengel, Dirk. So we now have the third interactive voting session for you, and what we would like to know from you now is what do you think? What source of information do you rely on most for your decision making, and that's for your clinical decision making? Is it discussions with peers that provide you with the information that influences your clinical decision making most, or is it congresses and symposia, or is it what you read in the scientific journal? Or is it maybe your clinical experience, your clinical intuition? So these are your four possible answers: discussions with peers, congresses and symposia, scientific journals, and intuition. And feel free to vote now, while we shall continue with the panel discussion. So this is a question to all the panelists that are here. It's good to have you all on one screen, finally, again. Also, so the question that we have for you is, so even though that the evidence shows low risk of ceramic-related complications, that there still seem to be a lot of concerns related to ceramic as an implant material. How would you explain these concerns towards ceramic materials? And maybe I'll just start from my screen, starting at the top with Professor Trebše. Would you have an opinion on why there seems to be a somewhat skewed risk perception, maybe with regards to ceramic implant material components? Oh, I think you're muted, Professor Trebše.
Yes.
Yeah.
Thank you for the question. Actually, there are two risks with the ceramic that are quite, let's say, important, or how to say, well publicized, and one that we don't know actually what is its importance. So one is, of course, fracture. In the past, the fracture rate of the former ceramics was relatively high, and the impact of a fracture on the patient was also very important. So a sudden problem without a previous announcement and the big problem and then the surgery and so on. So it does influence the consciousness of the patient, but also it does influence the view of the surgeon. So because it's a relatively catastrophic problem, and with the difficult to treat or difficult to manage issue afterwards, I think it does impact more than the actual problem was. But the issue is, like, we had quite some fractures in the past with the previous versions of the ceramics, but we also did the fracture analysis of those, and we noticed based on that nearly half of those were explicable by surgical mistakes, actually, or inappropriately. So it was not half of the ceramic fractures was actually somehow related to handling of these materials. So after the introduction of the composite ceramics, this problem actually nearly disappeared. So I think today it's just something from the past, this fracture-related issues. And the other is squeaking. Well, squeaking, when it was very important, I was hardly finding one single patient squeaking, even though ceramic on ceramic implants 15 years ago was very, very popular in our clinic. The problem is that it mostly occurred in US, and mostly with one particular implant, and mostly with poorly placed implant, which is quite frequent in US, where most of the surgeons do relatively low volume of the implant. So, but they are, well, how to say, rhetorically good, and they have quite good, let's say, possibility to share the opinion. So the US prevailed in this squeaking issue that I think it was nearly not encountered in Europe. But then when you see on every Congress squeaking, then you start thinking that it's a problem. It was not a problem at all in my institution. And maybe the third, just briefly, it is the load transfer in ceramic or all hard-on-hard bearing is different than if you have something soft in between. So you have this high peak load that we don't know what is the long-term influence on that. But knowing the new, how to say, knowledge about the metabolic explication of the Wolff's law, it's probably not detrimental, but maybe also have a positive impact on the bone below and above the implant. But let's wait that the time will tell us about that.
So ceramic cloud has a silver lining. What does the situation in dentistry look like, Dr. Stanley? What would you say? Oh, you're muted. Dr. Stanley, we can't hear you. You're muted.
Okay, can you hear me now?
Yes.
All right. I would agree with everything my colleague said, except for we don't have the squeaking phenomena. But I think, yes, I think the early implants, due to their manufacturing process, there was this early onset myth that they fractured. And I think, with these new modern implant manufacturing techniques, and obviously, hardened ceramics. I am in my practice, I've been working with this system now for 4 years. I have had absolutely no fracture issues whatsoever. I think that even a dentist without any real significant experience, but with the correct training, again, doing bone site preparation with a good technique, should not encounter any difficulties with this. And once the implant is placed in the bone, there's no indication whatsoever that these new modern implants will suffer any of the issues that titanium will have. And let's be clear that, I've been placing titanium for 20 years. I've had fractures in titanium, so they can also break. It all depends on the size of the implant, the load on the implant. So an average human can deliver 300 kilos per square centimeter with their bite. So it all depends also on the prosthetics, on the treatment planning. You can have the best implant in the world, but if the distribution of forces isn't done properly, that implant's going to break if it's in titanium or if it's in ceramic. So I think treatment planning is of paramount importance here as well. And you can't blame failures on, because of bad planning. even the best product will fail. So I think we need a lot more discussion moving forward. But I think I agree with my colleague. A lot of it comes down to myth. And without a doubt, I think that the future of dentistry, and this is a discussion that people are talking about, is a metal-free environment. And again, really excited for what's coming.
So it's a little bit of a bad echo coming over maybe from orthopedics into dentistry regarding regards to ceramics. Professor Stengel, what do you think? What's your opinion, having recently completed the survey?
How many days do we have to discuss this from a methodological
we
point
have
of view?
exactly, let's say, 45 seconds.
All right. Okay. So, I mean, what we had observed in our best evidence synthesis was that any event that was recorded is extremely rare, given the total number of implantations. So let's assume that the material per se is innocent, okay? But there is a complex interaction, of course, between the surgical process and ingrowth and whatever. To detect all these rare events needs a huge amount of data, which probably only could be collected in a registry today, because it would need probably a randomized controlled trial of 10,000, 20,000 patients or whatever to find one of these rare events. And on the other hand, you have that phenomenon which is called risk homeostasis, which simply means you exchange one risk to the other because there is absolutely no implant with a nil risk. Of course, you may have a certain risk with this one. You may have a benefit with the other. This is a health economic decision, a cost effectiveness decision, and also a risk benefit decision, because you have to count the numbers of events, of rare events, of adverse events with one implant material, and on the other hand with the other, and just see, well, where is what kind of balance do we have between the one and the other? So what kind of benefit do we have, and what kind of specific adverse events can be observed?
Thank you very much, Professor Stengel. We also have the response now for our third live voting session, which I will give you now. So 24% of you said that your most important source of information that you rely on for decision making is discussions with peers. So that's about a quarter of you that say discussions with peers are the most important source of information for you there. Another 15% say congresses and symposia are very important source of information. And half of you, 50% exactly, said that scientific journals and scientifically generated evidence that went through the peer review process is the most used source of information that you rely on most for decision making. And the rest, 12%, said intuition is a very important factor that you rely on for decision making. Now, when we are talking about concerns with regards to or risk perceptions, there's, we can have skewed concerns. Now, the traditional view is that, when you open up a textbook in psychology, for example, mostly you will find that, humans have all of these biases and we are very terrible at decision making and so on and so forth. What we found in our research was actually that a lot of the biases are in the environment. They're not, and our mind is just basically a mirror of that biased environment. So, for example, some side effects are asymmetric with regards to material components. A metal component or a ceramic implant may be more prone to fracture than a metal implant, which is happens kind of more short term after the surgery, ends up in the same profession, and is clearly noticeable, whereas metal implants may be more prone to cause kind of adverse tissue reactions, which are noticed later and may not be as obvious, right? So we have different ways that we get feedback about the success or not of using, for example, certain bearing materials. So this can impact, of course, the way that we perceive the risks revolving around certain choice of therapies, choice of material components. Do you think that this is an issue impacting medical decision making in general? Do you think there is enough awareness about these kind of topics that you have to be careful with your information environment when you do develop or when you rely on your clinical intuition? Dr. Trebše, maybe start with you again. Professor Trebše.
Well, yes, for sure. It's very important to rely on the clinical experience and also introduce the clinical experience into everyday practice based on that. But particularly going to let's say the discussion about the hip implants, for example, it does also influence the knee. It is important, as I initially also said, that we have this long-term result and we have this functional result. So it is based on the bone status, the other it is based on the soft tissue status. So patients do benefit if soft tissues are good. So if you are able, or an implant is able to preserve soft tissues until you have good soft tissues, or you can reconstruct them, you can still get a reasonable outcome after even a failed surgery. So if an implant is destroying, let's say, bone, but not the soft tissues, this is always reconstructible with a good surgeon and the knowledge about how to do with soft tissues. On the other side, if you have an implant, which we had an issue with metal, for example, or let's say infection or chronic dislocation or something like that, then you might have bone issues, but you have soft tissue issues that are not treatable. And this is the way that it's important, or this is the point that needs to be considered while introducing or selecting an implant or a treatment or whatever. So the functional status of the patient after the end of the treatment.
Thank you very much, Professor Trebše. Dr. Stanley, what do you think? Skewed risk perceptions in dentistry.
Well, first of all, you got to do your homework. I think that there's too many dental implant companies around the world where the actual dentists placing the implants get their training from the salesperson. There's no obligation to actually go and do the proper training, because a GP, a general practitioner dentist, is legally allowed to place dental implants in many countries without any very special training. And remember, dentists operate outside of a hospital setting that has all of the due diligence and corporate governance and other let's say due diligence and all of that. So a lot of dental surgeons are private operators where they're responsible for running their practice and the supply chain and buying the product. So obviously buying the cheapest product is very tempting for a lot of dentists out there. And this is a very scary subject that I'm quite passionate about, that we have a responsibility to choose the best products for our patients, and our patients need to have better information about what's going in their bodies. There's hundreds and hundreds of brands of implants out there. And I'm very pleased to say that, I know CeramTec and the Densilox department are very focused on something called, for example, Clean Implant Certification, which is a nonprofit foundation that actually measures with electric scanning microscopy the surface of the implants for contaminants that can fall on the implant during packaging processes, not to mention leftover detergents and stuff like that during the manufacturing process. So imagine this: you've got a great implant, but it's sterilized, but it's actually got contaminants on the surface inside human bone marrow. We have to look at these things a little bit more. So the scary thing in I guess moving forward is that a lot of doctors don't know what they don't know. We don't know what we don't know. And if there's no true oversight here, and remember, orthopedic surgeons work in a hospital setting. There's a lot of redundancy and backups and checks and balances that don't happen in dentistry. And it's a really scary place, because we're responsible for the entire sequence, and there's no police in dentistry. So we really have to look at this a lot better. There's a lot of great guys out there doing amazing things, but there's also a lot of bad actors and some companies selling cheap materials that can actually cause more harm than good. So I think there's a huge role to play moving forward and more conversations like this.
So it's an issue about medical risk perception versus financial risk perception then in some cases, I guess. Professor Stengel, very briefly, in about a minute, so we have the last minute and a half for one question from the audience, ideally.
Dr. Saleh, I love the phrase, we don't know what we don't know, and you're absolutely right, because there's too much evidence about things that really work compared to those that don't work. So, and of course, we have that certain type of publication bias when we always publish positive results instead of the negative ones. Also, especially in surgery, I mean, we have the problem of the so-called opinion leaders. And once they made a decision whether a certain implant is good or not, then probably the entire world will follow this opinion until there's a different one. So also we have a bias between general medical journals and specific journals and whatever. So from a methodological point of view, we have much to work when it comes to different materials and the reason why certain material has or is shown in some way in the clinical community. Yeah.
It also goes a little bit back to the point that you made. I mean, if you want to have the best evidence, you look at registries, but of course, registries only count a certain limited number of outcomes, endpoints, right? And if it's not counted, you can't look at the registry, right? So that's also a bias in the environment. There is a question from the audience, which I would like to pose to the panel. Very briefly, what is the status of periprosthetic joint infections after revision surgery? What do you think? What's the current status of after revision surgery? And so I would ideally like to ask Professor Trebše, who is our expert orthopedic surgeon. So after revision surgery, you've performed a lot of these surgeries. What do you say? What is the current situation with regards to periprosthetic joint infections?
Well, I think it is very important that in every revision, independently on when after the primary implantation it is performed, that all studies to diagnose infections are performed, because there always can be a hidden infection there. But in revision, you know, the infection rate is a bit higher, but it does not change. The view does not change in comparison to the primary implantation. So in early acute infection, debridement and retention of the implant is important. In infections when joint is debridable, so it is possible to do a good cleaning of the joint, and you have germs that are reacting to antibiofilm antibiotics, one-stage exchange is the best option, and for the difficult long-standing chronic prosthetic joint infection, a two-stage approach is preferred. So it's an algorithmic approach. I think that algorithms drives the best our treatment, independently whether PGI or other treatment topics.
Excellent, very good. Thank you very much, Professor Trebše. Going back to your first point, and that the best thinking is done outside of the actual surgery. Thank you very much to all of the panelists. It's been a great pleasure to hear from you and extract your knowledge and get your opinions on these topics. Thank you very much. And also thank you for the audience for your participation in the live polls, as well as providing us with some audience questions. We're sorry you couldn't get through all of those in time. Hope to see you all again, to the panelists. And thank you very much from Berlin.
Thank you to all.
Thank you. Bye.
Bye.
Goodbye.